Myself, Dr. Jibran Ahmed presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to discuss the part 1 of WHO classification of CNS tumor, sub part 2. So we are mainly going to discuss about the changes in the 5th edition of the WHO classification of CNS tumors when we are comparing it with the 2016 4th edition of WHO CNS tumor. So we have already discussed very important points, as in the grading system has completely changed. We are no more using these Roman numericals, so this is no more used. We are using Arabic numericals 1, 2, 3, 4 for grading of the tumors. Now the grading of the tumor is for each individual tumor type and not across all the tumors of the CNS. So grading within the types have been accepted, not across the types. Okay, this has been deleted now. Now we are not following across type, and for the grading, not only the histological parameters but also the molecular parameters are now used. Okay, several new entities have been added to the latest edition of WHO CNS tumor 5th edition. Now many other terms have been revised, as we have already seen. For example, your choroid glioma of third ventricle is now labeled as choroid glioma only. Similarly, ependymoma classification has also changed and revised in many ways. Okay, certain new tumors, okay, for example, astroblastoma has been renamed as astroblastoma MN1 altered. Now we are also having what is called as an integrated report, okay, wherein we have to, integrate many findings in the same report. For example, we have to write the location of the tumor, histological diagnosis, molecular findings, and then we have to give an integrated diagnosis, okay, for a particular tumor. And the classification has been further simplified, which we are going to understand in today's topic of discussion. So today we are going to discuss in details the changes that has been made to the latest edition of WHO CNS tumor, that is the 5th edition, and what are the differences from the 4th edition tumor. So for that, the first group of tumor that we are going to discuss, that is the gliomas, glioneuronal and neuronal tumor. So we are only discussing with respect to the classification and not the entity in details. So if you see, this is what was introduced in the previous edition or in the 2016 edition of the WHO CNS classification of tumors. Okay, that is the 4th edition. So if you see over here, that over here we had seen the IDH status, and for any kind of diffuse glioma, okay, any kind of diffuse glioma, we used to check this IDH status, and depending on that we used to label it as diffused astrocytoma IDH mutant, okay, or oligodendroglioma IDH mutant and 1p19 co-deleted. And we were having different types like glioblastoma IDH mutant and glioblastoma IDH wild type. But if you see in the 4th edition, all these different terms were used. But now any tumor that is IDH mutant is coming under the umbrella of diffuse astrocytoma IDH mutant. So in the 5th edition, if you see, the glioblastoma IDH mutant is not a separate entity. All of them, they are under diffuse gliomas. So this is now coming under the heading of diffuse astrocytoma IDH mutant only. So no more use of this separate term. But this glioblastoma IDH wild type is already there. Okay. Now also there are many other changes that has been made to the 4th edition. For example, this NOS term and NES term, okay, it is to be used in a different context, okay, that we will explain to you later about it. Okay, so very importantly, this was what was there in the 4th edition, and you have to read about these factors from the 4th edition so as to understand in details the changes given in the 5th edition. Okay, so let us move ahead now. So firstly, if we look at the classification system, before we go anywhere, okay, if you see, this is the classification which is given in the 5th edition of the WHO for the gliomas, glioneuronal and neuronal tumor. That is basically for the diffuse gliomas. Mainly this classification is given. So this is the 5th edition, and this is what was given in the 4th edition of the CNS. Now you can appreciate over here, initially only diffuse astrocytic and oligodendroglial tumors were basically placed under one category, and they had many divisions and many different types of divisions were there under this particular heading. And neuronal and mixed neuronal glial tumors were a separate entity in the 4th edition. But if you compare it with the 5th edition, they are now under one heading. All the gliomas, glioneuronal tumors and neuronal tumors, they are under one heading only. Now, very importantly, the most important thing that you are going to appreciate over here, that the gliomas, the diffuse gliomas have been divided into as an adult type and as a pediatric type. So there was no such division, okay, that were seen mainly in the previous edition. So no such division was there in the previous edition. Apart from that, we have a circumscribed astrocytic gliomas. Okay, these are those gliomas which are more contained growth, okay, which are having more contained or restrained growth. Okay, along with that, the glioneuronal and neuronal tumors, and then we are having ependymal tumors as well. So if you see in the ependymal tumors, it has been completely reclassified according to their site and location. For example, we are having supratentorial ependymoma, then posterior fossa ependymoma, spinal ependymoma, and then myxopapillary and subependymoma. So it is according to the location, number one. Number two, also the epigenetic and the genetic changes have also been included in the classification of the ependymal tumors as well. So this is a very big change that we have seen now, and the entire classification system has changed. Okay, if you compare the 4th edition with the 5th edition, the 5th edition has become more simpler as compared to the 4th edition. Okay, now if you see over here, the adult variety of diffuse astrocytoma, they are having approximately 15 entities over here. The adult type, they are having 15 entities, almost they are having 15 entities over here, whereas over here if you see, the adult variety is having just 3 entities: astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p19q codelated, glioblastoma IDH wild type. These are the only 3 entities that you will find under the adult type. Why is this change? Now just we are going to revise one important thing. As you remember, in the previous edition, the grading was done like this. There were 3-tiered grading system, okay, wherein the grade 2 tumors, so any tumor that was showing any kind of atypia, they were said to be grade 2. Any tumor showing anaplasia, okay, anaplasia along with increased mitotic activity was graded as grade 3, and any tumor which was basically showing microvascular proliferation, okay, microvascular proliferation along with necrosis, they were termed as grade 4. Okay, so this was basically the histological type of grading that we were doing, and this was also a clinical type of grading that we were doing, okay, previously. So accordingly, in the previous edition, if you see, if any tumor was grade 3, they were named as a separate entity as an anaplastic astrocytoma or anaplastic oligodendroglioma. Okay, so now the use of such terms has become deleted. Okay, we do not label a tumor directly as in with the grade. For example, if you see over here, there is anaplastic astrocytoma, okay, IDH mutant, anaplastic astrocytoma IDH wild type, so anaplastic astrocytoma NOS, like that. So this is not used anymore. Okay, if a tumor is having if it is having the IDH mutation, we call it as IDH mutant variety, and it is just an astrocytoma. Now depending on whatever the grade is, so beneath this particular tumor, we are going to now grade it as either grade 1, 2, 3, depending on several parameters, okay, and not only histological parameters. So any tumor grading is now within any type and not across all the tumor. For example, previously, if I am naming a tumor as grade 2 or grade 3, it was applied across all the entities. Now, every one entity, now in the current edition, every one tumor or any one tumor can have its own grade. Okay, we can assign grade 1, 2, 3, and this is very much similar to the previous to the other non-CNS neoplasm. So that has now also been adopted in the 5th edition of the WHO. So I hope this point is very clear, okay, to everyone. Okay. Now coming over here, okay, so basically gliomas, glioneuronal tumors and neuronal tumors, they are the most common and most varied tumor affecting the parenchyma of the CNS. Now the 5th edition has divided the CNS tumor, has divided the gliomas and glioneuronal tumors into 6 different groups. As I've already told you, number 1, there is an adult type diffuse glioma. These are the brain tumors that often forms the bulk of the adult neuro-oncology practice. Example, glioblastoma IDH wild type. This is the adult type diffuse glioma. Then we are having pediatric type diffuse low-grade glioma. Low-grade means these are having a favorable prognosis, and pediatric type diffuse high-grade gliomas, which are having generally aggressive tumor, okay, which is having a bad prognosis. Then we are having circumscribed astrocytic gliomas. Now circumscribed, basically it is referring to more contained pattern of growth as opposed to diffuse tumors in group 1, 2 and 3. So they are having a more contained type of growth. They are not diffuse. That is why we are club them into circumscribed astrocytic gliomas like pilocytic astroma. Then we are having glioneuronal and neuronal tumors. These are diverse group of tumors which are basically showing neuronal differentiation. And lastly, we are having ependymal tumors which has now been reclassified according to their site as well as their histological and molecular features. Okay. Now, previously, if you see the chordoid plexus group of tumors, okay, they were under the umbrella of gliomas, but now they have been separated from the category of gliomas and now they are actually a separate entity. So let me just show you all these changes that I have already discussed. So over here, if you see, this was the 4th edition, and over here chordoid plexus group of tumors, if you see, they were actually under the heading of the gliomas, but now chordoid plexus tumor, they are nowhere to be found under the heading of gliomas, glioneuronal or neuronal tumors. So chordoid plexus tumors are not a part of gliomas and this group of tumors, so it has become a separate entity over here now. Now, a number of newly recognized types have also been added to the classification of gliomas, as I have already mentioned. For example, diffuse astrocytoma MYB-BL1 altered, polymorphous low-grade neuroepithelial tumor of the young, diffuse low-grade glioma MAP kinase pathway altered, diffuse hemispheric glioma H3G34 mutant, diffuse pediatric type high-grade glioma H3 wild type and IDH wild type, infant type hemispheric glioma, high-grade astrocytoma with palloid features, diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters. It is a provisional entity, myxoid glioneuronal tumor and multinodular and vacuolating neuronal tumor. So these are the new entities that has been added to the classification of gliomas as well as glioneuronal and neuronal tumors. Now, the ependymomas, they have been classified in two ways, as we have already seen, on the basis of anatomical site and by the addition of genetic and epigenetic types. For example, supratentorial ependymoma YAP1 positive tumors, posterior fossa group A ependymoma, posterior fossa group B ependymoma, spinal ependymoma MIC-N amplified. Okay, so if we are just comparing the addition of the different types of ependymal tumors, so this was in the 4th edition. If you see, there was just subependymoma, myxopapillary ependymoma, ependymoma papillary, clear cell tantactic. So this was mainly histologically based. But if you see now, if you see the current edition of WHO, the ependymal tumor classification has changed according to their location: supratentorial, posterior fossa, spinal. Okay, and also certain epigenetic changes like and genetic changes have been introduced, like ZFTA positive tumors, YAP1 positive tumors. So this becomes very important. MIC-N amplified tumors. So again, these are the very important changes that have been introduced in the ependymal tumors. Now, for some of the entities under this group, for example, diffuse pediatric type high-grade glioma, the H3 wild type and IDH wild type, and for diffuse low-grade glioma, MAP kinase pathway altered. Now, the histological appearance and the defined molecular features, they must be combined to arrive at an integrated diagnosis. So, for certain entities, integrated diagnosis becomes a must, as for example, these two types. Okay, now there has also been type where there is a revision of the name or the nomenclature. For example, diffuse midline glioma is now designated H3K27 altered, okay, altered and not mutant, because there are various other manners in which this pathogenic pathway can be altered, and not just it is K27M mutant. So now it is K27 altered. Now also astroblastoma, as I already mentioned previously, it was just astroblastoma. Now it is specified as MN1 altered astroblastoma. Okay, so these are few important changes in the nomenclature that we have seen. Now, three major changes that has affected the classification and grading of diffuse gliomas, as I told you, that is, the pediatric type diffuse gliomas have been separated from the adult type, and the major reason for this division is that by this division, all these entities have been better identified, and it has resulted in better treatment for children. Also, the second important change, the adult type gliomas, the classification of the adult type gliomas has been simplified into only 3 types as against to the 15 types that was there in the previous edition. And lastly, their nomenclature and grading has been changed as well. As I explained you already, the grading system of CNS has completely changed and now includes molecular parameters as well. So division of diffuse gliomas into adult and pediatric type, as I already said, that and when I say that there is an adult type and there is a pediatric type, primarily means those that are under the heading of adult type, okay, will mainly occur in adults only, except in rare cases they might affect pediatric group also, and those entities under the pediatric group, they primarily occur under the pediatric age group, okay, and rarely they might affect adults as well. So primarily they are adult and pediatric type, okay, very important. And this was a very important step because this enabled better care of children with brain tumors. This is the first important change of this classification of gliomas. Second is simplification of the classification of common adult type diffuse gliomas. If you see, earlier there were 15 entities. Why? Because of different grade. Now every different grade tumor was having its own name in the previous edition. For example, there was anaplastic astrocytoma. Okay, that was a separate entity. Okay, so that is no more recognized. And very important, there were many tumor entities with NOS designation. Okay, so again, this NOS designation thing is not there. Now in this current edition, they have made very clear the term NOS can be applied to any tumor for which, you know, entire or for which molecular workup or all the testing was not successful or was not possible. Then the term NOS is used. That means further workup is required. And the term NEC means even after successful workup and having done all the tests, okay, we could not reach to a diagnosis, then we are going to see NEC. We are going to say the term as NEC. So in this manner, we have to use the term NOS and NEC. So completely, if you see, we have done with, we have got ridden of NOS and NEC, and this has to be used only in these settings that I have already described. Okay. So there are only three types now of, the adult type of diffuse glioma. That is the astrocytoma IDH mutant variety, oligodendroglioma IDH mutant and 1p19q co-deleted, and glioblastoma IDH wild type. Now the glioblastoma IDH mutant is the type of diffuse glioma. It is going to go under the heading of astrocytoma IDH mutant variety only. Now the very important, the third important change, as I already said, that is the nomenclature and the grading of common adult type diffuse astrocytic gliomas. If you see in the 2016 edition, the IDH mutant diffuse astrocytic tumors, they were assigned to three different tumor types. Okay, for example, diffuse astrocytoma was there, then anaplastic astrocytoma was there, then glioblastoma was there. So any diffuse astrocytic tumors, basically there were three different types according to the grade, and that depended on the histological parameters only, whether atypia was present or no, whether anaplasia was present or no, whether microvascular proliferation or necrosis was present. So depending on that, there was grading. In current classification, all diffuse gliomas or diffuse astrocytic tumors that are IDH mutant, they are considered as a single entity astrocytic tumor or astrocytoma IDH mutant entity. That's it. Now, depending on their histological findings or depending on their molecular findings, we are now going to grade according to CNS WHO grade 2, 3 or 4. Now, that should not be mentioned in the classification, just like in other non-CNS tumors, like how we do. So any entity is described, now depending on the histological features, we are now going to give a grade. So similarly over here, diffuse astrocytic tumors, so they are just astrocytic tumors IDH mutant, and then depending on whatever features are there, we are going to give a grade. Similarly, grading is no longer entirely histological. That means just if atypia is present, just if anaplasia is present, just if necrosis and vascular proliferation is present, so we are going to grade it as 2, 3, 4 respectively. No, it is not like that. Now many molecular alterations are also integrated. So for the finding of CDKN2A and or CDKN2B homozygous deletion results in CNS WHO grade 4 even in absence of microvascular proliferation or necrosis. So normally this histological criteria of necrosis and microvascular proliferation is assigning grade 4. Even if this histological parameter is not present and if we are finding such homozygous deletion, it should be labeled as CNS WHO grade 4. Okay, so now grading is not only histological based, it is also molecularly based. So for IDH wild type diffuse astrocytic tumors in adults, a number of papers have been reported that the presence of at least one of the three genetic parameters like TERT promoter mutation, EGFR gene amplification, and combination of whole chromosome 7 gain or whole chromosome 10 loss, they appear to be sufficient to assign the highest CNS WHO grade, that is CNS WHO grade 4. So diffuse astrocytic tumors which are IDH wild, see, IDH wild type means they don't have IDH mutation, that is a normal variety of IDH. So in those patients, if they have any of these three genetic parameters, then again we are going to label them as CNS WHO grade 4. So the fifth edition therefore incorporates these three genetic parameters as criteria for the diagnosis of glioblastoma IDH wild type as well. So any tumor, okay, glioblastoma IDH wild type, okay, so for the diagnosis of that, the presence of only these three entities, even if histological parameters are not present, is going to be taken as a CNS WHO grade 4 tumor. So as a result, IDH wild type glioblastoma can be diagnosed in the setting of IDH wild type diffuse astrocytic glioma if there is microvascular proliferation necrosis. So if they are present, well and good. If they are also not present, and if either of them is present, like third promoter mutation, EGFR gene amplification, or +7 -10 chromosome copy number alterations, all this is going to give a grade 4 to this particular tumor. Okay, so this is about the nomenclature and the grading of common adult type 4, common adult type diffuse astrocytic gliomas. Okay, so with this we have completed in details of what are the changes that has been there in the classification of diffuse gliomas when we compare it with the CNS 4th edition to the 5th edition. Okay, what is the difference in the classification? Next very important group of tumor that we will discuss, wherein we see a lot of changes, is the medulloblastoma. Now in medulloblastoma, if you see from here, so most of the things are same, but many new entities have been introduced and many other entities have been reduced. So for example, over here, if you see, this entirely medulloblastoma molecularly defined and histologically defined as same as it was there in the 4th edition. So this one is the 5th edition and this was present in the 4th edition. Okay, so if you see over here, the medulloblastoma genetically determined is the same. We have the same WNT variety, the SSH variety, TP50 mutant and the wild type, and we are having the non-WNT, non-SSH, that is the group 3, group 4 variety. So this is again the same group 3, group 4. So this is entirely the same. But what has changed, that if you see, these particular molecularly defined groups, they have been further subclassified and they have further many other groups. For example, the SSH variety is having 8 other groups. So the non-WNT, non-SSH variety is having 4 other subgroups. So there has been further subtyping. So that is showing that how much medulloblastoma is molecularly heterogeneous. We will discuss about this in detail. Now in the other CNS embryonal tumors, if you see, many of these entities are there, like atypical teratoid or rhabdoid tumor is also there. There is an introduction of this term, that is cribriform neuroepithelial tumor is new. If you see, embryonal tumor with multi-layered rosettes, if you see, it has been into one, and this NOS variety has been removed. Okay, CNS neuroblastoma, FOXR2 activated and BACOR ITD. Okay, these two are new entities again that has been introduced over here. Okay, so these are the few changes that we see over here. So let us read. So medulloblastoma, they display considerable biological heterogeneity, which is evident across the diverse types of molecularly defined medulloblastoma listed in the classification and among the morphological patterns shown by these tumors. Now, one important thing I missed over here, if you see, very importantly, medulloblastoma, the histologically defined varieties, like previously it was mentioned as classic variety, desmoplastic nodular variety, extensive nodular variety, large cell anaplastic variety, they were mentioned. But in the current classification, they are just written as medulloblastoma histologically defined. So what is the meaning of this? That means they are not carrying that much clinical significance as they should. So we can see that the importance of histological classification is coming down with every edition of WHO. Okay, so that is what is being reflected over here. And maybe in the next edition, we will not find this entity only. So this becomes a very important learning point at this point of time. So medulloblastoma, if you see, they can arise at all ages, but most commonly they occur in childhood. This is a tumor of childhood. Second most common CNS malignant tumor in childhood after high-grade gliomas, and it accounts for approximately 20% of all intracranial neoplasms in this age. The median patient age at diagnosis of medulloblastoma is 9 years, with peak in incidence between 3 and 7 years of age. As many as 1/4 of all medulloblastoma, they are occurring mainly in case of adults. Okay. Now, but less than 1% of all adult intracranial tumors are medulloblastoma. Now, the tumor has an overall male is to female ratio of 1.7:1. Now, it occurs in a setting of several inherited cancer syndromes like nevoid basal cell carcinoma syndrome, that is Gordon syndrome, Li-Fraumeni syndrome, FAP polyposis syndrome, Rubinstein-Tiabi syndrome, and Nijmegen-Brecken syndrome as well. Okay. Now, medulloblastoma, if you see, they are growing mainly in the 4th ventricle and they are located in the cerebellum, cerebellar parenchyma. So, some cerebellar tumors can be laterally located in the hemisphere, and almost all of these medulloblastic tumors which are located laterally in the hemisphere, they are SHH activated molecular group. Very important point. Whereas the WNT activated medulloblastomas are thought to arise from the cells of the dorsal brainstem, although not all the dorsal brainstem embryonal tumors are WNT activated. So these are just showing that there is some associations between the different molecular types and the location. Like the SSH type is in the lateral hemisphere, WNT activated in the dorsal brain stem. Now, all types of medulloblastomas are considered to be embryonal tumors, and they are CNS WHO grade 4 tumors. Even though some molecular groups and subgroups of medulloblastomas such as WNT activated tumors, they show a very good response to chemotherapeutic regimens, and therefore all these patients, they can be cured actually. Okay, all of these patients can be cured. So even if these tumors, some of these molecular types can be cured, till even though it can be cured, we are labeling them as grade 4 because it was already previously discussed. The grading was done in a time when treatment was not available, okay, and it was done keeping in mind the natural history of the particular tumor. So if these tumors, if the WNT activated tumor is not treated, then the patient will absolutely die in a very less span of time. So according to keeping that thing in mind, it was labeled as grade 4. But grade 4 tumor is also having certain other tumors which does not respond to any therapy, and patients die in a very less period of time. And over here in WNT activated tumor, they will respond very well to the chemotherapy, and they have a very good response to treatment, so much so that they can be cured. So in this particular situation, grading of a tumor always is not necessary, and therefore, because sometimes the grading can create a lot of confusion for the patients. Okay, so that is why grading is now a compromise in the current system of WHO. Now, basically, if you see medulloblastoma, these are small, poorly differentiated cells with high NC ratio and high levels of mitotic activity and apoptosis that we are seeing. However, the architectural and cytological diversity can manifest, histologically. There can be nodule formation, there can be neurocytic or ganglion cell-like differentiation, there can be even myogenic and or melanotic differentiation. Such varied morphological features can be seen across medulloblastoma molecular groups. Okay. Now we will look at the molecular heterogeneity. As you see, medulloblastomas, they can be classified according to a combination of molecular and histopathological features. Okay. Now this molecular classification reflects the biological heterogeneity that can be demonstrated by clustering of medulloblastoma into groups. So we can see that there are 4 principal molecular groups: WNT activated, SSH activated, group 3, group 4. That is nothing but the non-WNT, non-SSH activated. Now, tubers in the first 2 group, that is the WNT SHH group, they show activation of the respective cell signaling pathway. Okay, and they were also present in the previous 2016 edition. And the SHH tumors, they are divided on the basis of the TP53 status. They can either be TP53 mutant or wild type. Okay, anywhere when I'm using the term wild type means that particular gene is not muted. That is the meaning of wild type. Okay, and non-WNT group, they are having group 3 and group 4 tumors that we have already seen. Now, these group of tumors are represented in the current classification as well, but what has changed that a number of new subgroups have been emerged at a more tertiary level. So, with 4 principal molecules, so within this 4 group, WNT, SHH group 3 and 4, there are further more, stratification or further division is there. Okay. Now, these new subgroups are introduced in the sections on molecularly defined medulloblastomas. Okay, and there are 4 subgroups for SHH medulloblastoma, and 8 subgroups have been introduced for the non-WNT, non-SSH medulloblastoma. Now, like the 4 principal molecular subgroups or groups of medulloblastoma, some of these subgroups are associated with clinico-pathological and genetic features that provide clinical utility, either being of diagnostic or prognostic value, or they have implications for therapy. So one example is the delineation of the 2 SHH subgroup, that is the SHH1 and 2. So this delineation was important. Both are dominated by medulloblastomas which are from younger age group or from young children. Now, cases in these subgroups have statistically significant different outcomes, and recent clinical trials suggest that specific chemotherapeutic regimens can help those patients with tumors in the poorer prognostic group, that is SHH1. So there are different subgroups for the SHH. Now the subgroup, both of them, 1 and 2, they are occurring in young. But there is a particular study that given the current chemotherapeutic regimens, SHH1 is, basically they are having a more poorer prognosis, and chemotherapeutic regimen can help those patients who are in the SHH1 subgroup. So this is the importance of subgrouping under the molecular heading that we have seen. Now, the histopathological classification of medulloblastoma that was listed in 2016, that is the classic desmoplastic nodular with extensive nodularity and large cell anaplastic variety, they have now been combined into one section, that is medulloblastoma histologically defined only. Okay. So morphological patterns, they also have their own specific clinical associations, and they also have association with molecularly defined medulloblastoma. So all true desmoplastic nodular medulloblastoma and medulloblastomas with extensive nodularity, they align with the SHH molecular group, and most are in SSH1 subgroup and SSH2 subgroup. Okay, so this is very important. So desmoplastic nodular and that with extensive nodularity is mainly in the SSH molecular group and in the subgroup SSH1 and 2. Nearly all WNT tumors, they have classic morphology, and most large cell and anaplastic tumors belong either to SSH3 subgroup or to non-WNT non-SSH group 3-4 subgroup 2. So this is how there's an association between the molecular and the histological, or histology. Now, recent studies have described detailed genomic associations of medulloblastoma. Some driver mutations are aligned to particular molecular group. For example, PTCH1 is this gene is mutated mainly in the SSH activated group, whereas CTNNB1 is mainly seen. This mutation is seen in WNT activated group, whereas MYC mutation is seen in non-WNT non-SSH subgroup 3. They are found to be altered at a relatively high frequency, okay, when studies were done. A classification listing molecularly defined medulloblastoma while also recognizing morphological patterns with clinical pathological utility is intended to encourage an integrated approach to a diagnosis. So now comes the role. Now we are having now some histological diagnosis can also be associated with a molecular diagnosis, and therein we have to write both the diagnosis, both the molecular diagnosis as well as the histological diagnosis, and then an integrated diagnosis combining both of them. So combination of molecular analysis and morphological interpretation provides optimal prognostic and predictive information, as we have already seen. Therefore, integrating both the molecular and the histological diagnosis is of utmost importance in the current edition of WHO, 5th edition of CNS tumors. Now, medulloblastomas are one of the embryonal tumors, and there are other embryonal tumors as well. So the overreaching term CNS primitive neuroectodermal tumor, previously it was used, okay, it is now obsolete, it is no more used. Now the tumors discussed under the other CNS tumors, as we can see, we are now discussing this group of tumor. As we can appreciate, the other CNS embryonal tumors are the ones that we are going to discuss now, and we will see what are the changes that have been introduced over here. So over here, if you see the tumors discussed here, they are atypical teratoid rhabdoid tumor, embryonal tumor with multi-layered rosette ETMR, FOXR2 activated CNS neuroblastoma, and CNS tumor with Bakor ITD. These two are new entities that have been introduced under the other CNS embryonal tumors. Now, whereas ATRT and ETMR, they were there in the previous edition, FOXR2 activated and CNS tumor with Bakor ITD, they are new, as I already said. In addition, cribriform neuroepithelial tumor has been introduced as a provisional entity within this category, and CNS embryonal tumor is included for embryonal tumors that defy a more specific diagnosis. Okay, CNS embryonal tumor NOS, okay, or NEC, whatever. Okay. Now, for other CNS embryonal tumors, the diagnostic approach should seek the following. For example, biallelic inactivation of SMART CB1 that is seen mainly in ATRT. T19MC alteration or DICER1 mutation is seen in ETMR. FOXR2 activation, as we see, is seen in CNS neuroblastoma with FOXR2 activation. And again, heterozygous ITD in Bakor exon 15 is seen in CNS tumor with Bakor ITD. So these are the molecular alterations that we see in different types of these other CNS embryonal tumors. Now we will discuss something about the pineal tumors. Now, pineal tumors, if you see, they encompass a heterogeneous group of relatively very rare neoplasm affecting different age groups. So there are different entities over here. So you can see there is a pineocytoma over here. Okay, pineal parenchymal tumor of intermediate differentiation, pineoblastoma, papillary tumor of pineal origin. Now, what you will see, these tumors were also present in the 4th edition. So this is the 4th edition and this is the 5th edition. Okay, so over here, if you see, this is graded as the grade 1 tumor. This is in between grade 2, 3. Okay, this is again grade 2, 3. Okay, we no more cannot use, we have to write grade 1 like this. Okay, no Roman numeral, only Arabic numeral. Pineoblastoma is grade 4 tumor. And whereas this is a new entity that has been introduced under the section of pineal tumor, that is desmoplastic myxoid tumor of pineal origin SMART CB1 mutant, and this has no grade as of yet. No grade has been defined for this tumor. Now, very importantly, molecular profiling of pineal tumors has segregated basically the pineoblastoma that we have seen into 4 subtypes. Pineoblastoma, microRNA processing altered 1, arising in children, characterized by DICER1 DROSHA DGCR8 mutation, as well as by intermediate outcome. Whereas pineoblastoma microRNA processing altered 2 in older children, it is characterized again in mutation in dicer1 drosha DGCR8 mutation. Outcome is excellent for this group. Pineoblastoma MYC FOXR2 activated arising in infants and is characterized by MYC activation and FOXR2 overexpression, and there is a generally poor prognosis for this. Pineoblastoma RB1 altered arising in infants and showing similarity with retinoblastoma with a frequent metastatic spread and a very poor prognosis. Okay, so this is all about all the changes that have been there in the pineal tumors that we have discussed over here. And lastly, we will see certain changes that is there in the SELLAR group of tumors. So tumors of the SELLAR region, they include diverse set of pediatric and adult neoplasm. They are arising in the region extending from sella turcica inferiorly to the floor of third ventricle superiorly. So very important thing is, based on the current understanding, we have seen that there are additions of new tumor types and modifications of existing tumor types in the 5th edition of WHO of CNS tumors. In the past edition, very importantly, there was a separate heading of craniopharyngioma which was having adamantinomatous and papillary variety of craniopharyngioma. So they were under a single umbrella. But now this common umbrella term of craniopharyngioma is not there, because this adamantinomatous and papillary variety, they are itself a separate entity altogether. So they are distinct entities. They have the distinct biological and molecular features. So they have been separated as a distinct entity and they are not under the heading of craniopharyngioma. Secondarily, we can see that pituitary adenoma or pituitary neuroendocrine tumor, PITNETs, they have been included in the 5th edition because they were typically resected by neurosurgeons and diagnosed by neuropathologists. Again, pituitary blastoma, a rare embryonal neoplasm of infancy composed of primitive blastomal cells. Okay, they have been added as a tumor type again in the 5th edition of CNS tumor, and these are strongly associated with germline variation in dicer1 gene. So with this, we have mainly discussed in details the differences in the classification of the tumors between the 4th edition of WHO CNS versus the 5th edition of the WHO CNS tumor, and mainly we have discussed the major tumor, not each one of them, but we have discussed the major tumors. Okay, so with this, we are going to end this part 2. Thank you very much for watching this particular video, and do subscribe, like and share. Thank you.